Hi, Amita.
Hi, how are
I'm
you?
good. You can hear and see me okay?
Yes, can you hear and see me okay?
Yes, perfect. Yeah, it's so nice to meet you.
Thank you so much for doing this. I've been looking forward to it for a
Oh,
long.
awesome. I actually earlier today made a bunch of like documents and I'm going to upload into this particular module like reference sheets. So I'm prepared and I'm going to give you some, you know, reference materials. So you don't have to memorize everything I'm saying and all that.
Yeah, no, that would be great because I actually typed out a bunch of questions I
Oh,
had.
perfect. You're so prepared.
Yeah, this is a topic I'm really interested in. So, and I don't know anything.
Yeah. So are you a med student or a resident
No,
or
I'm a psychiatrist.
you're a practicing psychiatrist? Okay. And you're in Los Angeles and then do you have a private practice or do you
So I just graduated from my child fellowship in 2018,
mhm.
and I'm actually doing telepsychiatry right now.
Okay.
I don't know if you've heard of TBH.
Yeah, transition behavioral health.
Physician
Yeah,
therapy.
yeah, I have.
So I work at a clinic in Contra Costa County in the Bay Area.
Uh-huh.
So I do 3 weeks a month, Monday through Thursday, of telepsychiatry, and I go up there 1 week a month to see kiddos. And I work with kids mostly, but I mean, I'm boarded in both adult and
Yeah.
child,
Yeah.
so open. I'm open to both, and
Yeah.
definitely have a lot of questions. So
Okay. Well, so tell me a little bit about how you got interested in integrative. Like you said you don't really know a lot, but like what's your experience with it or what got you interested in it in the first place?
So, I mean, I know a little bit because of just my cultural background. I'm from India. I just actually got back from there.
Oh, oh yeah.
Different things they do there around mental health that are not strictly just psychopharmacology. So that's kind of where my interest started. I haven't read up much on it, but I think a little bit of it is just I don't know how to say this in the right, like maybe a little bit of frustration with the tools that we've
Mhm.
been trained in. And I don't know if you can relate to that,
Yeah.
but I think when a person comes to me and they're really struggling, I sometimes have had outcomes where I'm just doing med after med after
Yeah.
med. And a lot of my colleagues, and like when I was in residency, that was the case too. And they were augmenting and they were doing all this different stuff, and it really wasn't working. And I think that people really, at least some of my patients, a lot of my patients, like they kind of use meds as a last resort, and they don't
Mhm.
like the side effects that a lot of them have,
Mhm.
especially antipsychotics,
Yeah.
that
Yeah.
those types of things. And so I think that's where my interest, that's why like I wanted to talk to you about it, because I saw your video on how to deal with anxiety from
Mhm.
and that just like it was like a light bulb in my
Yeah.
head. I was like, this really resonates with me.
Yeah.
And it seemed like you were having a lot of good results with your approach. And so I think that's kind of where my interest came in.
Yeah, I remember feeling the same way I think it was in residency, toward the end of residency when I was doing outpatient, and just like, is this all we can offer people? And it's great when it works, and often it does. You just prescribe a medication, and then,
Yeah.
especially for anxiety, then the person gets better. But then what do you do all those other times when it doesn't? And then, yeah, once you've tried 6 medications for someone and it's not working, you have to consider if a different modality is
Absolutely.
better. And that's kind of what I think about the principle of integrative psychiatry, is that it's sometimes it's misunderstood as replacing medications with supplements. Like, oh, don't prescribe Prozac, prescribe St. John's wort. But that's not integrative medicine. That's taking the silver bullet approach of a molecule for an illness and then just changing what the molecule is. So yeah, you can use supplements and nutritional supplementation and herbal medicine and all that, but it's more like if you have a medicine and let's say the medicine helps a little bit, and then you do CBT therapy and that helps a little bit, and you do some dietary changes and that helps a little bit, and you're layering on these approaches. No one treatment has to solve the problem. And
Yes.
you end up often needing lower doses of medication for shorter periods of time. And the patients love it because they feel like, they don't want to just go straight to medication, and they feel like you're listening. And so then you really get the benefit of, honestly, the placebo effect, because this is the other thing about integrative psychiatry or integrative medicine is you're respecting the preferences of the patient. So if they say they want a medication and that's what they believe it's going to work the best because they had a family member who took Prozac and they think it's really going to help, then prescribe them that, you know, and then if it doesn't work, do something else. If you have someone because of their cultural background or their personality or just personal preferences, they really don't believe in that, or they really want it to be second line, do therapy first, or just ask them what get a sense of their expectations. And so this is another thing that I do, or one thing that drove me crazy in residency and in medical school too is when someone would say, hey, I'm interested in this supplement, or I want to try this, and they'd say, oh, well, there's no evidence for that. Because to me, that's the dumbest thing to say, because there's no evidence for that. Well, does that mean they haven't studied it? Does it mean they've studied it and it doesn't work? Does it mean they've studied it and it's mixed results? Have they studied it and there's harm? I mean, those are all completely different things. So one of the principles of integrative medicine is how you look at evidence, how you evaluate evidence. Because people who are like in academics are more, what's the word I'm looking for? You know, like don't believe in it or more critical of the idea will say, well, there's no evidence. But what you have to look at is what is the evidence that it works proportional to the evidence that it's harmful. Yeah. So if you have a treatment that's potentially really harmful, like just say chemotherapy or surgery, where there's potential toxicity and side effects and costs, then you want to be really sure that it works. You don't want to just be like, oh, I have this feeling it's going to work. You know, you need like level grade A evidence that this works, double-blinded placebo-controlled trials and all that. If we're talking about something like meditation, I don't need a Cochrane review that meditation works. I mean, like the cost is low, the side effects are low, the toxicity is low, potential benefit is it's not going to cure someone's psychotic disorder. I mean, I wouldn't use it for psychotic disorders, but you know what I mean? But the potential benefits say moderate. Yeah. And then I don't need any more evidence. Or exercise. Like, I don't need to read 600 research studies on exercise to know I should recommend exercise or recommend not eating processed foods. And the same is true for a lot of, say, supplements or nutritional medicines. Some you really do have to be careful about side effects, but some, if the patient just says, if they say they're interested in supplements, I have a list of like 5 to 10 in my head that have little to no potential harm that I'll recommend to them that have some potential benefit. And then that makes them happy. And then they're maybe willing to try the medication too, you know? So it's a lot of it is about building rapport, and you're not trying to force something down their throat, but you evaluate what they believe. And then you like the line I use is you sell them what they want so you can give them what they need, you know?
I like that.
As long as what they want isn't harmful or insane or dangerous, like why not give it to them? Or like,
right. You said like so much that kind of resonated with me just there, because, you know, I was in an academic center for residency, and there is this sort of culture of just like disposing of this stuff. Just, oh, that's, you know, that's just snake oil stuff. That's not anything that has any evidence behind it. And like, I think when I've seen my attendings, you know, sell it to patients like that, then they just don't want it because they're like, well, it's just not.
Yeah.
I can see that they just get really disappointed because I think they're wanting to try something else.
Yeah.
So I think, you know, I'll be honest, I myself had to go through a process where I was like, well, does this stuff really work? Is there evidence? Like,
yeah,
evidence. But then like, I think, so I actually had a patient who was on N-acetylcysteine for trichotillomania. Or, I mean, she had trichotillomania, and I gave her a NAC, and like, it worked really, really well.
Yeah.
And I didn't have to give her any other prescribed medications. And I think so that's when I also started thinking about this concept of evidence too. Like, are we not offering patients tools that could be helpful because of this idea of evidence?
Yeah. It always bothered me because I felt like not everyone, but sometimes my attendings had no humility. Like,
yeah,
what were we doing 50 years ago in psychiatry, or, you know, 80 years ago? I mean, it was completely insane, and it was
Right.
all sorts of things that we would do, and it was very sexist and very, women were hysterical and all this stuff. And then, so of course, yeah, it was the best, and the medications we had, but it was the best we could do then.
Yeah.
But the idea that we have it all figured out now, and there's nothing we don't know, is absurd. In 50 years, when we look at what we're doing now, and we're like, oh my God, we prescribe people antipsychotics for anxiety. Like, what are we doing? Or, we'll just have more knowledge and more science to understand what is so intuitively obvious. And so you take ancient healing traditions. Even things like meditation or mindfulness or Ayurvedic medicine or traditional Chinese medicine that maybe aren't studied or weren't studied 2,000 years ago, but it's from trial and error. Like there's got to be something to it. I mean, they didn't just randomly give things that never worked and then that's that, so there's.
Yeah. And I think that the concept of intuition, because when I was in India, it's just people, that sense is really developed.
Mm-hmm.
Into practitioners there, and I mean, of course, there's lots of issues there as well in terms of mental health, but that, I like how you said, like, there are these things that you intuitively know.
Yeah.
We're waiting for the studies and the evidence to kind of catch up with that.
Yeah. Right. And it's like sometimes I see studies, I get the little APA, daily emails or whatever, where they send you this, and it's like, study shows that exercise is helpful. I was like, someone studied that? Like, that's just so dumb. I mean, no, it's not dumb, but it's like, I don't know if that, I don't need more studies on that.
Yeah.
So.
Children should cut down their TV.
What'd you say?
Children should cut down their iPhone use.
Exactly. Like iPhone use associated with higher levels of depression. I'm like, yeah, okay. That's a rocket science, No, I know someone has to do the research and stuff, but I think sometimes evidence is used as a crutch rather than a complementary tool with intuition. They're not mutually exclusive. You can use them together. My goal with practice is to be wise, and sometimes being wise is you have to have some flexibility and fluidity and not just need to be, right according to one particular dogma.
Mm-hmm. Did it take you a while to get there though, to really accept that, like using your intuition and because like in residency, we're not taught that stuff.
Yeah. So for me, it was, I remember in medical school, like in the clinical years, just having a sense of like something we're doing is wrong. Like I couldn't quite put my finger on it. And then same thing, the first 2 years of residency, like, why are we doing this to people? Like, why are we like a lot of patients are helped and they're happy, but some aren't. And I'm like, what's that? Why are we so mean to patients sometimes? And then third year, I just happened, we had therapy supervisors as I signed up to see this guy, because I thought he did one thing, but it turns out he practiced integrative medicine. He actually practiced functional medicine, which is a little bit of a different thing. It's like analyzing lab values and like balancing internal molecules. And so it's a subset of integrative medicine. But so he started teaching this stuff, and then he recommended I go to this conference, the organization's Academy of Integrative Health and Medicine, AIHM.org. They used to be the board certifying body, but they're not anymore because now it's an AB, American Board of, it's like a physician specialty with all the other board certifying bodies. So, but they do a fellowship and they do these annual conferences. And so anyway, I signed up for this annual conference the fall of my third year, and it just immediately I was like mind blown. Like everything they were teaching, it was like the missing thing that I felt that I hadn't heard before someone say so eloquently. And like a lot of the thing I said about evidence, that was a lecture at this conference. I was like, oh my God, that makes so much sense. So it was like 6 of these lectures a day where everything was like, oh my God. And they're quoting evidence and they're talking about clinical cases. So after that, I was, completely 100% on board. And then I kind of got to, what I did after that, because I was still in residency, I I had therapy patients, so I was really just doing therapy with them. But I had, my outpatients. I would kind of like throw in a few things in the 20-minute appointment I had with them, or my moonlighting job. I would order some extra lab tests and interpret them, or I'd teach someone like a really quick 5-minute meditation or so. I just kind of tried to practice. And then it wasn't really until I had a private practice that I could really go full on with integrative medicine. But I did find small ways to practice before.
And so how did you, so it was mostly through this mentor that you learned this stuff, or did you like download like things from that website? Like how did you
Yeah.
all this knowledge and amassing all this knowledge?
Yeah. So it was like, think of it as a lifelong learning, and also you're one at a time adding things to your repertoire. So this guy taught me a couple things, and then I went to that conference and I learned a lot there. And I went to the conference maybe 2 or 3 times after that, but I just started reading. So I really taught, like it was self-taught and this conference. So like I'd go to the conference and there'd be, some books they were selling from the lectures, and I'd buy the books and then I'd study the stuff. And then like I had a textbook on nutritional medicine, and it, would say, okay, for anxiety, try inositol, and try lavender, and try 5-HTP. And so I'd be like, okay, I'm going to try lavender, and I would just recommend lavender for someone, and then I'd see what happens, and then they'd say it helped them, and then that would be in my toolkit for things I'd recommend in the future. And if someone ever asked about something, I would research it. Like in my practice, I advertise an integrative psychiatrist. And so sometimes people call me and they mention like, oh, do you know about this thing? And I'm like, yeah, totally. And then I'm like looking it up. And so I kind of learn one step at a time. And what I actually did is I have all these documents on my computer, like from Evernote, it's it's kind of like a Google Doc. And every time I learn something new or I practice it, I put in that Google Doc. So I have a reference of here's my toolkit of things I do for this particular illness. And so it was really trial by error. Wait, is that, am I saying that? Trial and error. But also it's with keeping certain principles in mind. So that concept in the anxiety video of biology, psychology, and behavior. Really everything in psychiatry, you have to do something in each category, at least something in 2 of the categories. Right. So it was like, okay, what's my toolkit for biology? Well, it's going to be medication. It's going to be nutritional supplementation or herbal plant-based medicine. What's my toolkit for psychology? It's really going to be CBT. What's my toolkit for behavior? It's going to be really, say with anxiety, it's always avoidance or negative cognitions. But it's always like, the negative cognitions is more the psychology, but it's usually going to be avoidance or perfectionism. So I assess with each patient, what are the main blocks that someone is having? Because I think of illness not as, oh, you got to take this sick person and force them to be well. Like you got to manipulate their brain. It's more our natural state of being is wellness. So you have to identify what in this particular person is the block to that, and then remove it. And with anxiety, I really do have a very specific protocol. I'm actually put it in the course, so it'll be available. It's like all the, yeah, like let me pull it up right now. Obviously there's medications and supplements, and there's like 15 supplements that I use listed. I give sleep recommendations. I do CBT, mind-body practices. So that's obviously things like meditation, mindfulness, or yoga, acupuncture, Tai Chi, but it's also, say, cranial electrical stimulation, or the placebo effect, or looking at heart rate variability, which is, it's a sign of high cortisol and chronic stress. And so it like a form of biofeedback essentially. So, and then what else do I have on there? The lab tests I order, and you can get a sense from that document of what the principle is, like how you can create your own protocols for each illness. So think of it as per illness. So like, let's say, I don't know much about integrative medicine for kids because I just, I don't know what's not as safe for them. But like, let's say you treat whatever the most common thing you treat is, and let's say it's depression. You're like, okay, I'm going to read all about integrative treatments for depression. I'm going to read like these textbooks, or these reference materials. I put a list of the reference materials I recommend, like the conferences, the textbooks, and all that. Like, okay, I'm going to read about what the potential, say, supplements are, what the potential behavioral approach is. And say before I see a patient, I'll do that if I haven't done it before. And then I'll use that as like a reference to how I'm treating particular patients. So like when I started my practice, someone came in with trichotillomania. And I was like, so I created a whole treatment protocol for trichotillomania. And like I studied how to do CBT for trichotillomania, which I didn't really know, like habit reversal therapy. And so I use patients as a way to get proficient in a particular illness rather than like.
Okay, so it's not like you didn't know like habit reversal therapy before in residency. You just kind of like kind of learned about it and applied it as you're going along.
Exactly. Like, look, think of each patient as an opportunity to become very proficient at one particular illness. Mm-hmm. And then, so think of it less as how do I use this supplement? Think of how do I treat this illness? And then you can do reading on that. You can create your little Google document, and then you can try it and you can see what works and what doesn't work. And you can see what patients like and they don't like. I would actually say that to me, those two things are equivalent, like what they like. But my goal when I see a patient is to have them have a positive experience. It's not just to have them get better because those things are overlapping. So I want them to come out feeling good about the treatment they got, which then will therefore they will feel better.
So how does so if like someone came in with trichotillomania
Mm-hmm.
and it was an initial evaluation, how does that usually go for you? If you don't make me ask, like what would how would that go if you didn't know how to do habit reversal therapy, things mm-hmm. like that? Like, could you give me an example of how your session goes for you?
Yeah, well, I would say because I have private practice, I know what the main thing they are coming in with ahead of time. So I don't know if it's that way with telepsychiatry. You probably don't know till you show up, but so yeah, I'll like know in advance because they'll call me on the phone and we'll have a 5-minute or 10-minute conversation, and then I'll look it up when they're there. But like, let's say that they also have something else, or something else is their primary problem. I essentially do a regular psychiatric assessment that I'm not really asking too many different questions. In fact, I would say that I get a lot of my information from a prior, like I have people fill out a health history form in advance, like electronically, and I ask about, so I have all their medications in advance and medical problems, and I also ask about sleep and dietary habits and exercise habits and supplements they take and all this stuff and substances. So I have the advantage of kind of knowing already what I'm going to do prior to the appointment. But if like I'm kind of caught off guard or something I don't know, I'll kind of fake it till I make it, honestly. The main thing I do that maybe is different from other people is I say a third of the appointment for going over the plan. Mm-hmm. Like, so the first, I still do like a 90-minute appointment, even though I know probably before the appointment and within the first 2 minutes what I'm going to recommend. But that first 2/3 is about getting this person to feel comfortable. Like, so it makes it easy. That's my only job is I want this person to feel heard and listened to. And so I might ask them questions I don't really need the answer to or already know the answer to, because that process makes them feel good. And then a lot of what I'm doing that last third is explaining why they should take a prescription medication. So that's part of it too. Instead of just saying writing a prescription, it's how do I make this person feel good about this medication? And then I'll offer, say, other supplements but I would say actually the way I don't do everything at once. I do it in a specific order, and it's usually medication first because that's what's going to get the person probably better the fastest. Like a general principle is that like medications work faster and have more side effects. Alternative or complementary approaches take longer to work. They're more subtle and have fewer side effects. So you kind of want to like bring out the bigger guns first get that person feeling better, like somewhat better in a couple of weeks, then they feel happy. And then you use the alternative approaches or complementary approaches to get them off the medication sooner or make them feel like they're making continued improvements.
Okay.
So sorry, I'm probably like being a little circuitous in how I'm explaining this, but so for example, someone comes in with anxiety. I start an SSRI. I spend that last third of the appointment explaining why, even though they may be hesitant, it's still potentially helpful. So like, what do I say? I'll use analogies. You maybe have heard these analogies, like it's like with a broken arm, like you break your arm, you don't try to just like wobble around with a broken arm, you get a cast on, and then the bone heals itself, but the cast helps stabilize the arm so it heals properly, and then you get the cast off. So I'll say medications are like that. It helps reset a negative circuit that's in your brain where just negative thoughts, it resets it. Or here's another analogy, like imagine a cart going over a dirt road, and it goes over the same spot over and over and over again and develops ruts in the road. And then after a while, that cart can't steer out of those ruts if it wanted to. And that's what's happening right now with your depression or your anxiety. What the medication does is it fills in the treads, it fills in the ruts. And then eventually you could take away the medication, but you can steer your own cart. So I use these analogies that explain that it's a temporary bridge. It's not like you are now dependent on this and like you're now addicted and all that. So then usually they're like, oh, okay, like that makes sense. And I, explain all the side effects and I kind of am reassuring. And then they come back a couple weeks later. And then depending on what their preference is, and they may get better and then not care about any integrative approaches. Like they may have come in like, I want integrative medicine, and then they're better and they're like, I'm fine. But at that point I might start doing CBT, and I'm teaching them life skills. I'm teaching them, how to challenge negative automatic thoughts, how to address avoidant behavior, how to face their fears. I'm always giving them homework assignments and exercises and checking in about it. And then I may start recommending some supplements. So like, oh, the Prozac's helping, but sometimes I have like anxiety. I don't want to use like an Ativan. I'm like, okay, well, we can use lavender. We can use L-theanine, which is the compound that's in green tea. It's like a relaxing compound. We can use valerian root. So I'll kind of just, depending on their health history and what they seem that they like, I'll recommend, say, some supplements that they can try, and maybe it'll work or not work. But like usually at this point, the person feels better. But then if they're not, then I escalate the options, but I won't try 60 different medications. I'll say, okay, let's try cranial electrical stimulation. I have these little alpha stim devices that it's like, do you know what that is? You put it on your ear and it puts.
I used it, but I know what it is.
Yeah, I have 3 of them. I love it personally. Like it helps me sleep, and so I have some devices. I'll loan them out to people, and then if they like it, they can buy their own device. And so I'll do that. Or sometimes then what I'll do is the specialty lab tests. The company called Genova Diagnostics. It's like questionable. I don't know how evidence-based they are, but it's like this very extensive nutritional testing where this person will get like a 12-page report on all their micronutrients and amino acids in their body and their blood. It like looks at the difference between blood levels and urine levels. So it's a functional nutritional assessment. It's not what's your objective level. It's, is your level high or low for your needs? And it evaluates that by looking at the Krebs cycle and where you're backed up, essentially. So if you have a lot of a precursor, then it presumes that you're missing a cofactor to get to the next step.
Okay.
Yeah.
Genova Diagnostics.
Genova Diagnostics.
So what about if you like have a patient who like comes in with like a border, like mean like they come in, they present with like anxiety, and then like over the course of 1 or 2 sessions, you kind of get an intuition that this could be more personality driven.
Yeah.
borderline personality disorder, which may not respond to medications. Like,
Yeah.
and they just, I mean, because like I think the experience I have is like they're like, doctor, nothing is working, nothing is working, nothing is
Yeah.
what they're needing is just really good DBT or good therapy. And unfortunately, where I work, like we're really backlogged.
Yeah.
You get presented with that, or if a patient's very, very high needs, how do you respond to those? Has that ever happened in your practice?
Yeah, it for sure has. And to be honest, I don't know if I fully know the answer to that because I find those patients challenging too. And I've had that happen where, the person comes in with what seems like maybe straight anxiety. And then like, I'm thinking of this one patient, actually the woman who had trichotillomania, who had for sure like avoidant personality disorder. I mean, she missed like just every appointment. She'd come in the last like 2 minutes and and I was prescribing her benzodiazepines, but I never got a chance to discuss with her why we had to tape her off. I mean, it was just like a disaster, and I ended up discharging her, and she wasn't mad. She kind of understood why. I did have, I could kind of close my practice now, but I had this patient who came in for integrative treatments, and she probably does have chronic fatigue, and so I did a little protocol for that. And she has anxiety, but she also is borderline, not like horribly dysfunctional, and not in like a hostile way. So but she's a little annoying. She would send me a lot of emails, always about like some crazy supplement she wants to take. It's always like, oh, and she's putting herself on all these things. So I develop rapport with her by kind of accommodating her when I can. Sometimes she'll want to take a supplement, then I'm like, look, you can't mix that with all these other things, or I'm just not familiar enough with it. You can't take those herbs at the same time as this. So it's kind of like having her feel comfortable and corralling her a little bit. And it's interesting because for her, I don't really feel like I did much, but she feels like the care is like the greatest thing she's gotten because I'm just making her feel comfortable, So sometimes you don't even have to have a great plan or one perfect thing if you like figure out how to make the patient feel good. But I've had patients who are like borderline narcissistic, and I ended up discharging them, or they fired me, and I wasn't that helpful to them. So I don't know if integrative medicine is always the right approach for in those cases, or it can be helpful, but there may be something else that needs to be addressed. And another thing to really consider, say if you have a private practice, is you will get people who are coming to you, if you're advertising as an integrative psychiatrist, who are seeking you out because they're personality disorder. Like, so if they come in like nothing's working, I've tried 60 medications, no one listens to me. I mean, sometimes that's true, but like I've gotten better after seeing some of these patients. It's like, they want you to read 600 pages of their records and talk to their, 12 doctors. And now I'm just like, I don't think it's a good fit, So you have to keep like an eye out for that too, because people are asking for certain things, but they really have a different issue.
Yeah, like, so this is more of a private practice question. How do you discharge patients? Like, how do you, like, I mean, I can imagine that's hard.
Yeah.
Like, what is your process of doing that?
Okay, so I learned this through like necessity and through making like mistakes and having things like not go well. And I actually read a couple of books. One, The Power of a Positive No, like it's a negotiation book. The other is called Boundaries. And like there's certain protocols for how to say no. So The Power of the Positive No, it's about figuring out what your yes is. To the point where it sounds like something you can reasonably communicate to someone. So for example, I saw this patient for just the intake, and I was like, I cannot handle this person. Like, she came in, she brought her dog, and she didn't tell me, and she immediately wants to hug me, and like she's crying. I'm like, okay, wait, hold on. And then I'm saying, I'm sorry, I'm not comfortable hugging you. And then she's like, I'm really offended because you wouldn't hug me. And I'm like, oh my God, I can't do this. So after the appointment, I'm like, I just felt this sense of dread of like, how am I going to get out of this? So negotiations and discharging a patient or telling someone you can't work with them is a negotiation. They're won or lost prior to when you're trying to talk to them. So you have to prepare. You can't just expect to come up with the perfect thing to say in like spontaneously. So the first thing I did is I wrote this down. I was like journaling. I was like, what's the reason I don't want to see this patient? I was like, okay, it gives me a sense of dread about the future. It stresses me, that just the idea stresses me out. She'll take up so much time, and it'll take away time from patients that I like working with more. And then I was like, oh, that's something that I could almost say, like, like, oh, it will take time away from the patients I have now. So I formulated what I was going to say based on that. I said, look, I need to talk to you about something. I always say the no or whatever it is I need to say first, because if you just like, oh, I've been thinking and this and that and whatever, and then at the end they're like, wait, what did you just say? Like, they don't know if you said no or yes. Like, so just say, I've been thinking about this and I'm not going to be able to see you as a patient. Pause. The reason is, and then you say the reason. So there's no, like, they don't know what's going on. So the reason is, you have a high level of needs. There's nothing wrong with that. You're in the right place you are coming to the right place, seeing a psychiatrist. You are genuinely really motivated to improve. I admire that about you. Because you're doing that, you are going to get better. I, though, am not the one to treat you, because in terms of the bandwidth I have and the experience base I have, I'm not going to serve you best. And it's going to take my time and energy away from the patients I currently have that I have to be committed to first over, say, a potential new patient. I'm going to give you some referrals. She was like, oh my God, am I too needy? I'm like, well, honestly, like, you are too needy, but I don't mean that in a negative way. I mean that your needs are too high for what I can do. And, to be honest, I've had this situation happen before, and it ends up being stressful for me and for you. Like, it's not a positive treatment experience for anyone. And I don't want to do that to myself, but I also don't want to do that to you. And then, they'll have questions and you answer them, but I don't recommend lying, because people aren't stupid, and then they'll like they'll have an answer for whatever the thing you made up was. Like they're like, oh, I don't have time to see you 3 times a week. Oh, once is fine, or twice is fine. Like, oh, well, like, just come up in advance something that's true, but also kind, and you'd be amazed that people like can listen to that. So that's like how I say no, say like up front. Now, the other thing is, what if you have a patient that's slowly pushing boundaries, and it's kind of like you're the frog in the pot of boiling water. What do I do? So you set boundaries in stages. So I don't start off like with my first visit, like, don't ever do this, don't ever do that, because it's kind of harsh. I set some limits, like, you need to come to appointments and this and that. But I don't want to be harsh, like step 1. But let's say someone starts crossing a boundary. Like, let's say someone just starts calling a lot between appointments, but not coming to appointments. Like, that's something that's happened. First, you verbalize the boundary. It's really important for you to come to your appointments, and we're not going to be, or you just say it's really important for you to come to your appointments. You verbalize what they need to do. Let's say they don't do it. Then you verbalize the boundary and you say a consequence. It's really important that you come to your appointments as opposed to calling just between appointments. If you continue to not come to your appointments, I'm going to not return your calls between appointments. And then let's say they keep doing keep pushing it, and they're still missing appointments and calling you a crisis and stuff. And, so I told you that in order that you need to come to your appointments and not coming between appointments. And if it happens again, the consequence will be that I will no longer be able to work with you. And then if they keep doing it, then you do the consequence. Unfortunately, like we said, and these, I'm not going to be able to work with you anymore. And at that point, they know, like, you told them the whole way. You didn't just like what you don't want to do is like hold it up inside and then boil over and just fire them. And then like I've done that before, and it like did not go well. And so you want to give them increasingly like increase their requirements until it's something they can't meet, like assuming, not to be mean, but assuming it's something that you need them to do for your work to be effective together.
Yeah. Yeah. Do you have patients calling you like in crisis a lot between appointments, and how do you structure like the calls in between? I think I read on your website actually that you like what you
Charge. Yeah. And to be honest, I actually, in practice, I don't really charge. So I say that I do because I don't want to be called carelessly, or I don't want people to be like trying to save money or something by not paying for the appointment and then like trying to get all their needs met in between. That was a learned skill. I mean, so in the beginning, I didn't really understand how to handle it. So saying up front that you charge is good. And then I kind of follow that same steps of like limit setting. So I assume at first someone's calls are reasonable. Another thing is I used to have an after hours line. I got rid of it. I tell people I'm only available Monday through Friday during business hours. That saved so much of my sanity because I never in like a year got a single appropriate call on the weekend or evening.
Yeah, I could imagine.
So, and you don't legally need to do it. So I just told everyone I no longer have this after hours number. I'm only available at these times. And like, there was absolutely no negative consequence. So that saved my sanity a lot. If someone's doing it a lot, I'll purposely wait before returning their call. Just setting this expectation, I'm not immediately available, because if you are like, if you're giving them what they want when they're doing something, it doesn't matter if you tell them don't do this. They're not going to hear what you say. They're going to hear what you do, which is you return their call like in like 30 minutes. So you have to like not do that and make them wait. And then, depending on the particular situation. And then I actually get more emails than calls more recently, because like I just try to direct people toward email because it's a little easier for me. And I'll just answer their email. Like if someone's like sending lots of these questions, I'll answer it really quickly, like in a sentence or two. And I'll say, let's discuss further at your next appointment. And that tends to end it. It kind of just sets the expectation of like, oh, okay, if it's a long thing, I need to come to the appointment.
Mm-hmm. Okay. And then I had one more question. I had
Mm-hmm.
more questions, if that's okay. So
Yeah, of course.
So in between appointments, so yeah, so when they have questions after hours, like they're having like a side effect to their whatever, or they're in crisis, they're suicidal, do you direct them to go to the ER, or how do you?
Yeah. I have it on my voicemail. If this is after hours on the weekend, if this is an urgent issue after hours on the weekend, please call 911 or go to your nearest emergency room, or call the LA County mental health crisis line at blah, blah, blah phone number.
And then how do you liaison like for coverage? So if you're on vacation or.
I have a colleague who covers. Like we cover for each other if we're on vacation.
Okay.
Yeah.
Cool. So was it, how long did it take you to build up your practice and to actually like, and how did you advertise?
Yeah.
And how did you recruit patients?
So I already had my blog, and I already.
Which is amazing, by the way.
Oh, thank you. Thank you so much.
Amazing too.
Thank you. I drew on eyebrows.
Oh, so beautiful. I want to ask you how you were feeling too. I mean, I have not asked you that yet.
No, I mean, I feel okay. It's like, I'm tired, but it's like I'm slowly but surely getting better, but thank you. So I already had my blog, so I would get Google searches through that. But honestly, if you are an integrative psychiatrist, people are searching you out. Like people want that. So having a website in general is really good, because think about it. If someone gives you a referral, what do? You Google that person. And if you Google 3 people and 2 have like crappy websites or no website, and one has a website like me and it has like all, you can read about me, you feel like you know me in advance. It's a win-win for the patient, and it's a win for me too, because the person is self-selecting to see me because they like what I have to offer. As opposed to you just show up to someone and you're like, I don't like this person, it's not a good fit. that happens very little in my practice at this point, or right before I had to go on leave. So like once it got going, I was getting just Google searches and referrals, but then I did advertising. So Google ads, I got a ton of patients from Google ads. It's a little bit of a learning curve of how to not like hemorrhage money doing it, or like what you write in the ad. But honestly, if you just put like integrative psychiatrist Los Angeles, people are Googling that. You just create a little ad. And then Psychology Today, I got a ton of referrals through Psychology Today, which is like $35 a month, or I mean, it's just like some crazy little amount. And if you look up my Psychology Today profile and then read anyone else's, you'll see like most people write really crappy profiles. It's like, I graduated from law school and I treat all sorts of mental illnesses with a variety of modalities. It's like the patient's like, what the hell are you talking about? You tell a story like, I believe in this and this is what I do. And so if you just write, like most doctors are no good at advertising or marketing. So if you're just a little bit better than bad,
Yeah.
it will really stand out. And then just being an integrative psychiatrist, so what helped me, all those are specifically, I actually didn't go after referrals like a lot in terms of talking to other doctors and saying send me referrals, because first of all, they'll send you people they don't want to take. Like if a psychiatrist sending referrals is only sending you people like that they don't want to take.
Yeah.
Referrals from psychologists are fine, but then you can't do therapy with them because they already have a therapist. And having people who have funneled through your website to me is ideal, because they like have read your whole thing and they kind of already know before calling you that they want to see you, you know, like, so you're not convincing them. They're not hemming and hawing on the phone. You know, like I got really good at this but like in the last, year, where they're just like, no, I just like to schedule. They don't care about my fees. They don't care. They're just like, no, I want to see you. And they feel good about it before they even come in the door. I mean, that's ideal. You've already developed rapport before they even come in the door. So I really think a good website with a lot of kind of personal information of storytelling about who you are and how you got there, and where someone can just get to know you, is the ideal way to develop a practice.
Well, I can imagine for you too. I mean, like you're an incredible writer.
Oh, thank you.
I mean, it's so authentic and so genuine. And I think that, like, I actually started following your blog. I switched from pediatrics to psychiatry.
Oh, no kidding.
Yeah, I did a year of peds and then went to psychiatry. And your blog was the first one that came up.
Oh, wow.
I didn't know what the hell psychiatry was.
Yeah.
And I definitely felt connected. And I think that made a difference. I'm sure that makes patients want to see you too, because I know how to your writing. And so do you feel like having a blog like that's important if you do a website, or just have kind of a website with your services and a short little about me?
I mean, a blog involves some work, but I think it's better. I mean, because it's those stories, like when I wrote my personal story about cancer, I was not, like, the first time, I was not thinking ahead of this is going to help my practice. I mean, I didn't know if I was going to live. I mean, I didn't know if I was ever going to work again. And then when I did start my practice, I was like, oh, there's all this personal information. Like, it's very not what you're kind of taught in psychiatry, which is like blank slate, don't give anything personal. But it ended up just being a benefit. Like, people, kind of like you're describing, they're like, wow, I feel like I know this person, or this resonates with me. And if it doesn't resonate with them, then they don't call me. So I do think if you have the time or the inclination, it's good. And two different kinds of posts are good. The personal story, it can be related to psychiatry, of kind of how you came to psychiatry, or just like how you personally apply something you do with patients, because with integrative medicine, you have to practice what you preach. And so kind of a story related to how you learned how to challenge negative thoughts or meditate or whatever. So those kinds of posts, and then also kind of how to informational, because I have a lot of like, how do you supplements to treat anxiety? Those are like, I kind of wrote the title specifically because I knew people Google it. Or like when I was writing the psychiatry posts, like I have one called Sample Psychiatry Personal Statement, because that's a very Google thing. And so I get a lot of hits that way. So you can be strategic of what you title it, something that people Google related to, like, oh, I'm looking for how to treat depression with integrative treatments. And so how to treat depression with integrative treatments. And you just talk a little bit about it. Someone will read that, like, I want to see this doctor. And you can even have a little blurb at the bottom, like, to work with me, go to my practice page here, or something like that.
Mm-hmm. Speaking of that, like, and I don't know if this is a little bit more of a personal question, but do you divulge things personally? Like, I mean, of course, therapeutically, right? Like,
Yeah.
Psychiatry, we can never do it, but I know that for my therapy patients, some of my most powerful moments were when I did kind of therapeutically just say something about my own life.
Yeah. Yeah.
Like, do you do that with your patients still, or like, is it kind of like
No, I do, like, strategically. Like, I usually don't, unless they've shown some interest in, like, I mean, they almost all, or most of them, kind of know the background because they've seen my blog, but I usually won't go out of my way to bring it up unless they kind of, like, I had someone who had a tumor, and it ended up being benign. He was worried it was cancer. He's like, I know you kind of know about that. And so he was kind of like, I could tell, wanted to talk about it. So then I would, like, I know what you mean, and it feels scary, but we don't know yet. And I would describe when this happened to me, I really thought, this is going to be the worst. This is the most horrible thing. But then you adjust, and you may not, your situation may not change, but how you feel about it will change. That's what happened to me. So I will kind of sparingly talk about my personal experience. Yeah. It's actually a part of cognitive behavioral therapy. It's one of the tools, is a strategic personal disclosure.
Is it most of your training in residency for CBT, or did you get extra training on top of?
I did a year clinic on PTSD, like prolonged exposure for PTSD. But honestly, books, like, what are those? Like, all of those treatments that work, like CBT for, like, honestly, that's what I did with that patient with trichotillomania. So I have, like, every like, someone comes in with social anxiety disorder, I'm like Amazon priming the treatments that work. And then also, what's the guy, Aaron Beck, what's his daughter's name? Judith Beck. Mm-hmm. She has a basic cognitive behavioral therapy book. So I read that. She has one for personality disorders, and then also, like, CBT for challenging situations. Like, I just have like 10 books, and I didn't read them all at once, and haven't actually read most of them, like, all the way through. But I have someone coming in, I'm like, oh, I gotta, like, read this, and then and I'll just try to, like, implement a few things at a time. Like, a patient coming in for CBT therapy, they don't need to know, like, you just got to know enough for that appointment, and then you learn it for the next appointment. Right. And I found that to be a really rewarding way to learn, because I didn't have to know everything in advance. This is actually a huge problem in medicine, where it's such a conservative field, and it's so, like, they drill in perfectionism to you. Like, if you make a mistake, you're irresponsible, you're going to get sued, you're going to lose your license. And so people come out of, like, 12 years of school thinking they need more training. Like, oh my God, I need to get the fellowship. Now I need to get, like, another certification. It's like, no, you do not need any more certifications. You just need to start doing it. Like, and you'll learn. Like, you don't have to know everything in advance. Like,
that's just so good to hear that, because I am a new graduate. Like, I mean, I've been doing it for a year. It's so true what you say. Like, I mean, I think because we're so used to being in school all the time. Yeah. You just feel like where do I go from here? Like, what do I do? I don't know what I'm doing. Like, I need to, like, read this and, like, go to this training and that training and all these things. It's very compelling to do that,
Yeah. It's seductive, because you're like, oh, then I'll know enough, and then I can. And I actually think that, so the Integrative Medicine Fellowship, say through the AIHM, is great. It's integrative medicine, though, not psychiatry. So you're learning, like, all of medicine, and it's very expensive. I think it's great, but I think you don't need it. Like, no one who comes to me is like, are you board certified in integrative medicine? Especially because it's like a couple of years old. It's not it's not that established. So it can be kind of a trap to get certifications. And I've done a bunch of other certifications, like, but after a while, it's like, I don't need any of these. I have enough degrees. I can just learn something. And I think it's much more anxiety provoking. Like I thought I was going to have a panic attack like every day of seeing patients for the first, 6 months. Like they're going to know I'm a fraud. But then it's an exposure exercise. You just do it and you're like, oh, I feel good. And I remember when I first started feeling like, wow, I'm really competent at this. I mean, it's a rush. It's like, and it didn't take that long. It maybe took a year. And then obviously I'm still learning and everything, but that long for me to be like, wow, I'm better at this than most people. This is really good. Like I can help almost anyone who comes into my office. Like it felt really good.
Such an empowering feeling. Like, because I definitely got into that trap that, I have to go to New York City and get like this certification in family therapy, family systems approach, and psychiatry. And I was contemplating doing that fellowship actually in integrative medicine.
Yeah.
I don't know if it's an integrative psychiatry fellowship in Arizona. I was contemplating doing that, but then it's good to know that it for you is just more like reading and going to conferences and that type of thing, kind of applying it from there. Because I do. It's funny because like when I first said that I don't know anything, I actually do because I read a lot about this stuff. I just haven't practiced it.
Yeah.
I just don't do it. Like, then so in terms of the malpractice thing, do you worry about with integrative medicine or integrative psychiatry like that because a lot of these things aren't evidence-based that like about the malpractice piece, or can you comment on that?
I mean, like in the beginning, I might have, because like you train so much anxiety. Like if you don't document perfectly, if you don't consent on everything, but that's not actually true. If the patient likes you, they're not going to sue you, and you don't have to be perfect. Patients do not expect their doctors to be perfect.
Right.
Like, I remember even when I had cancer, and like there were some mistakes made in my treatment, but I loved my oncologist. Like I wasn't going to sue him. I mean, that just was like a ludicrous idea. It's like a relief if you just have a good relationship with your patients and you're responsible. Like none of us is like careless. So if you went to medical school, you're a conscientious person. Like you probably don't need to be more conscientious than you are, like more perfectionist. Just have a good relationship. And if you make a mistake, sincerely apologize. Like, I don't know why they say don't apologize. Like that never works well. Just even if like I had a patient who she came to me for anxiety, and it wasn't until like the third appointment where she said something like her boyfriend having arsenic poisoning. And I was like, what? Like, oh, he was kidnapped by the CIA. And I was like, oh my God. And it turns out she was psychotic. And like she wouldn't take any medication, and eventually prescribed her just gabapentin because it was the only thing she would take. And she said she had a big side effect from it. She maybe did, or it probably was also partially kind of her expectation about it, like psychological, because she had this negative association with medications. Anyway, she was like furious at me. And I was like, oh shit, okay. Like even though she's psychotic, I just apologized. I was like, I am so sorry. I did not go into medicine to make people feel worse. And I'm so sorry I prescribed you this thing that made you feel worse. And anything I can do to make it better. And this is what I suggest we do. We're going to get you off of it. Or we're going to, and she was still upset and she didn't see me after that, but she was like, calmed or whatever, like it's hard to stay angry at someone who apologizes to you sincerely. You know what I mean? So, now, like maybe my malpractice carer would say that's not enough. Like you should do these other things. And I do try to document well, but I don't know. I'm less worried about it now. The more time that goes by and everything has gone well.
That's good. That's awesome. Was it hard in the beginning to take that leap because I read your blog about how you started the practice, but was it hard to just kind of take that jump to do your own thing? Because it's really easy to kind of like work for a healthcare system, especially the psychiatrist. There's so many jobs out there, and for me, like, and a lot of my colleagues have taken that leap to do private practice is sort of hard. Like, was that something difficult for you? And then
I mean, yeah. So I didn't just like graduate residency and start my practice. I mean, technically, like on paper, that's what I did, but I had not been seeing patients for like 4 years.
Yeah.
I mean, the level of insecurity I had, like whatever you feel, multiply that by 1,000. I I couldn't remember how to dose Lexapro. I mean, I didn't remember like basic things about medicine and psychiatry. I forgot how to write a prescription. My DA license had expired like 2 years before, and I had no idea. You know, I mean, I was just like freaking out. And then I did not feel ready to work, but my disability ended. I mean, and that makes sense because I had finished chemo, and then they continued it for like maybe 3 or 4 more months. But they're like, yeah, no, we can't keep doing this anymore. And so I had no money, and I needed to get a job. I had a semester left of residency, but honestly, my program director just graduated me. Like, I didn't see any patients, or I kind of went to some lectures. Thank God, because the idea of going back to residency, I thought I was going to have a heart attack. I mean, I was just so anxious. I had to do one of those like exams where you're observed interviewing a patient, you know.
Yeah. Yeah.
And my friend, like someone who was a co-resident but now wasn't attending, did it for me. I mean, it was almost humiliating, you know, like, no, I mean, he was super nice but it was just like, you know, him evaluating me and me not doing a good job. I mean, he didn't say I did a bad job, but I was like, I didn't know what to ask. I didn't remember any criteria for anything. And then I was like, I just need a job. And so what I was going to do was moonlight for Kaiser. So I did the application, I like interviewed, they were onboarding me. And then I went to a colleague, like a former attending of mine. I like went through my evaluations and just saw who gave me a good evaluation. And I went to him to get a letter of recommendation for Kaiser, went to his office. And he's like, yeah, totally, I'll give you a letter of rec. But, you know, like he and this other guy had this office. He's like, we have a spare office because the other person left. Like, do you want to start a private practice? And I was like, yeah, maybe, you know. But I was like, I need to think about it. I always knew that was my goal. But honestly, the idea of that is terrifying to me. But I just, it took like 2 months, you know, to do the Kaiser onboarding, and I was kind of like deciding then, and just at the last second it kind of said I can't do Kaiser. I actually did one day and was like, no, I'm not going to do it. Felt so bad. And then I started the practice and I had 0 patients. My colleague who former attending started sending me patients. The first patient I saw, I mean, I literally thought I was going to have a panic attack. First of all, I did not even have furniture in my office. I got furniture like the day before the patient was coming. I had no way to write notes. I just got some paper and I mean, I had no way to bill. I saw the first patient. I did not have a way to bill them. I didn't have a merchant account. But honestly, that was such a good learning experience, that experience of not being prepared and just doing what you had to do to get to the next step, because there was nothing wasted. I didn't waste a bunch of time preparing for something that I never needed to do or know. I just did exactly what I had to do to get to the next step. Oh my God, this person's coming in. Let me get a psychopharm reference book and look up the medications for this thing. And that's why I literally was in a state of anxiety for that first, say, 6 months or so. But then I was like, I got it. So if I can do that, you can for sure do it.
Really good story. So many of us are just private practice, we don't know, it's blah, 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 blah. So that's really good to hear.
Yeah.
Just was good.
Yeah. It was a good lesson. And I'll tell you this, it's a very entrepreneurial mindset. The doctor mindset is be totally 100% prepared in advance or you're a failure. The entrepreneurial mindset is the minimum viable product. Just do enough to be able to do the next step. And it's much scarier, but it's much more efficient. And you learn information that's much more important. I don't know, I couldn't recite to you a lot of integrative medicine stuff. I mean, that some people who've done the fellowship can do, but I can practice it, because I know I don't know kind of arcane things. I know the most important things for the most common disorders. Mm-hmm. Mm-hmm. So it works for me.
This was really helpful. This was super.
Yeah.
Much. This was really, really helpful.
Oh, good. I'm so glad.
Other people find that this was helpful too, because I feel a lot of my friends who are interested in it, there's so much gray,
Yeah.
And not a lot of, and so I think that this was really helpful for me to process my own feelings about starting a private practice, which I've been thinking of for a while.
Yeah, totally. Especially if you're interested in integrative medicine, it's it's so great. And I'm also a control freak. So I couldn't imagine having a job now.
Yeah.
You have to use this annoying EHR, something like that. Like I can, any problem in my practice or any inefficiency, I can fix. I can change something. I can change my office policies. I can change what I bill. I can change how my office is organized. Like I just love it. So anyway, I'm so glad that you found it helpful.
Yeah, no, seriously, it really was. It really was. Because like I've just been, I work with quick kids and I've been frustrated. And I mean, I love my kids. I love my patients. And for working for a system, it's actually a really good job that I have.
Yeah.
But I think that I've always had this different mindset,
Yeah.
And I've been wanting to start a private practice where I can do more meditation, yoga, supplements, things like that. And I feel like I just need like a push to like start thinking along that line,
Yeah. Yeah. And if you like, is your job salaried, your current? Yeah, you could always, you can't start a practice with a salary job, but if you say have like a moonlighting job 1 or 2 days a week, that's the best way to do it, because then you're not super stressed about getting patients. I didn't do that. I was like, oh my God, I'm not going to be able to afford food. But then I really got it going. There's something about desperation that it would have been less stressful. So, but you could also just save some money and then have, say, 3 months of expenses. And
there are some people who do like 3 days of a salary job, and then they do like a private practice for 2 days.
Oh, yeah.
They like transition that way.
Oh, okay, yeah.
Well, I mean, I may consider that too. I'm an office, so I would have to like. I mean, I would have to find out like where I would practice and things like that. So.
Wait, what did you say? You're what?
I'm in Los Angeles.
Oh yeah. I could probably send you some patients. Honestly, like I had I had to send out all my patients when I was sick. So I'm gonna have to start a practice again at some point, but it'll be easier the second time. But I had a lot of patients like, do you know another integrative psychiatrist? I was like, no, I don't. I'm sure there are some in LA, but I didn't know anyone. So
that's really interesting. How are you feeling overall? I mean, I know it's been like bone marrow transplant and all that stuff.
Yeah, I'm kind of doing fine. It's a little, so I'm tired. I'm like 70 something days out of the transplant, and I haven't had any complications, so you worry about infection or graft versus host. So that's all going well. It's hard to not be productive. That's kind of the same thing I felt when I was sick the first time. So that's part of the reason I wanted to do this course. And also I want to start seeing patients as soon as I can, at least via video. I can't really go to the office because I have an infection risk. So I try to stay productive, but I'm just kind of tired, but I'm not sick. And mentally I feel pretty good. I have my husband who makes things so much easier than when I went through it the first time. So it's amazing, that psychosocial stuff, how I did the same chemo initially as I did the first time. And the first time I was so sick and throwing up every 5 seconds and pain. I was taking opiates, and this time I had none of that. And from the same drug. So I was like, oh man, it's really interesting how that works.
Isn't that interesting, that psychosomatic piece?
Mm-hmm.
I mean, I find that really interesting too.
Yeah.
But this was really great. Thank you so much for doing this.
Yeah, absolutely. And feel free to keep in touch via email if you have follow-up questions.
I will. Yeah, I was in India, so I will be much better about keeping in contact.
Oh yeah. No, I felt bad because I hadn't checked my email in a while. I'm so glad. I was like, oh, thank God she's not free yet. Because I come so flaky.
Yeah.
So it was perfect timing because my parents were in town actually through yesterday. So I was like, Friday's perfect. So, but for sure, email me when you start your practice. And then also I'm going to email out to the course when I put the video up, and then you'll see those other documents. If you want to look at my anxiety protocol or any of the other stuff. I
will. Thank you so much.
Yeah, absolutely.
Definitely I'll be keeping in touch with you.
Okay, perfect. Have a happy and belated holidays, but I hope you have a great rest of your day, and we'll be in touch. Bye.